What I'd like to tell you is that you're at the top of the game. So we've mentioned to you that the Fontan registry is unique and that it places us at the top of the research in the field. It places you at the top of the research in the field, but you're in a bit of a funny game as well. Days like this, specific for Fontan, do not happen throughout the world. So you're part of the best research in the best teams, and you're the most informed one, and maybe too informed. The people tend to say that you should not give to the public information before the information has been peer-reviewed and published. That means that when you do the research, you write your article, you send it to super experts who throw bits out and ask to put other bits in, and that's the real information. And before that, it should not be over to the public because it's not true somehow, because it has not been confirmed as truth. Well, we're doing things differently. We've completed this liver and renal study now. We have not completed the analysis yet, and yet we are ready to give you the results. And it's unfinished, and it's not interpreted. But if you don't do that, what happens? Some of people in Melbourne have participated in that study already 2 years ago. And so if we want to wait that it's peer-reviewed, you're going to have to wait, sending the manuscript, review, waiting for being published. You're going to have to wait an extra 2 years, 4 years before you get the results. So maybe we're doing wrong by communicating that to you, but that's what we do. Can I ask you, who in the room knows that you have some consequences on the liver and maybe the kidneys when you have a Fontan circulation? Do you know? Who knows? Who has no idea that there may be an interaction between the Fontan circulation and the liver? So there's a few people who don't know. Who participated to this Fontan and liver study here? Okay, good. So first of all, I have to do some warnings, but most of you are aware that there may be consequences on the liver when you have a Fontan circulations. And so there may be strong words, and whatever I do, I invite you not to be scared by them, and I'll put things into concept, and so don't get too excited. I have to give some disclosure. That's in all scientific talks. Normally you have to do that. And I especially want to do that with you because my main area of research is Fontan outcomes. And I'm a consultant from some pharmaceutical companies. And I don't get a lot of money, as you can see so far, but it's prestigious to be asked by companies to give advices. And I find it always very funny because I have to sign all these tons of confidentiality agreement paper, and it takes you about 3 minutes and an internet connection. If you read the name of the company and my profile, you know exactly what they are trying to do. But I cannot reveal it to you because there's confidentiality agreement. The other disclosure is obviously I'm a surgeon, and I'm going to talk to you about things I know nothing about, which is liver and kidney function. So Kirsten very well explained to you how the Fontan circulation is working, and the things to understand is that the heart ejects the blood, it goes through the microcirculation, and it's still able to generate between 10 and 20 millimeters of mercury of pressure in the veins, and that's one of the main driving forces with the natural breathing for the blood to go through the lungs. So if you make that in comparison to a normal circulation, what I tend to say now is that the pressure in the veins is about 4, 5, 6 times higher than in a patient, say in somebody who's got a normal heart. And that put pressure on the liver and the kidneys. So the concept that you can have an impact on the liver when you have increased venous pressure dates from the 50s from chronic heart failure. So when your heart is failing, you have a buildup of pressure in your left ventricle, it goes into the lungs, into the right ventricle, into the vein, and then it impacts the liver. What is cirrhosis? Cirrhosis is scarring of the liver leading to its dysfunction. If you have hepatitis, you destroy liver cells, and then the destroyed liver cells get replaced by scar tissue. Or if you drink heavily and boozing after boozing, then you destroy your liver cells, same thing. You have scarring tissue, and it's kind of progressively, the scar tissue has strangled your liver and it doesn't function anymore. And so it has been identified for a while now that if you have a Fontan circulation, and we've seen that on people who have died, but of other causes as well, they examined the liver and they saw tract of scar tissue, of fibrosis into the liver of people with a Fontan. And the more time goes by, the more you would have fibrosis. And yes, there has been people identified with cancer of the liver developing, because if you have cirrhosis, you can have cancer developing. I'd like to reassure you, because I say the magic word cancer, my belief now is that if you're a female with a Fontan circulation, you have more chances to have a breast cancer than having a liver cancer, and if you're a male, I would suspect that you have more chance to have a prostate cancer than a liver cancer. But still, it's something that we need to examine, because even it's very rare, it has been seen happening, and it may be promoted by the fibrosis in the liver. What we tend to know is that everybody with a Fontan circulation tend to have a fibrosis. In all of these cases, we have dilatation of the veins coming out of the liver and going into the circulation. And even though we see fibrosis scar tissue, it doesn't seem that it impacts how the liver function. The liver, for those who don't know, is this big machine taking care of the proteins, all the building blocks of your organism, and taking care also with the metabolism, the dealing with the sugars in your body. So we've set up the scene. We have maybe some issue with the liver. How do we examine him? We have lots of different possibilities to investigate the liver. What should we do? So we have, on that purpose, did a study that was funded by the NHMRC to examine what's the extent of the problem and how we should investigate this problem. So the aim of the study was to determine the proportion of patients with liver cirrhosis, fibrosis, or maybe carcinoma, cancer, to screen for liver abnormalities, and to find out what is the best screening tools, and to define also those who would have a renal impairment, because what is true for the liver is true for the kidneys, and there's much less data on it, and we thought it was a good opportunity to check both at the same time. So we did a fibrous scan, and I explained what it is. We did a study to get a nuclear scan study to examine the renal function of the patients. We did examine the urine with the albumin creatinine ratio and explain what that is. And we checked an ultrasound. We checked on the blood the alpha-fetoprotein, which is a marker for cancer. We looked at the peripheral venous pressure, and some people have said if you take the pressure on the arms, it reflects the same pressure inside your lung arteries, inside your central veins. We look at in the blood all the liver function tests, and by amalgamating these different tests, we can have a score of fibrosis. We looked at clotting factors, and we look at the echography of the heart. So the fibrous scan is this new non-invasive investigations where it's a little machine. You see the little probe here. It sends some sounds inside your body, and the sound is reflected by the layer that you have inside, and the way it's reflected, the time it takes to go back to the probe, tells you a little bit the amount of scarring that you have. And so you have a number, and following the different conditions, you can put a score of fibrosis of the liver. And you see, for example, hepatitis here, you see alcohol, and you see nowhere Fontan. So we have no idea with the numbers that we're generating what it means for the Fontan circulation. Because the limitation of the fibrous scan is that if you have congested hepatic veins, so if your liver veins are congested, which they will be if you have increased venous pressure, we know that it gives you artificially a higher number. So likely the FibroScan will be very different in a Fontan circulation than with the other condition. But it may be interesting to look at what you have at 1 year and what you have 5 years later. So it's interesting to investigate, because the alternative is maybe only, liver biopsy, getting a piece of liver and looking at it at the microscope, which is much more invasive. And there's not much studies done in children and zero in Fontan patients, as I explained. The nuclear scan injections, it tells you how much blood the kidney can filter per minute. So how much the kidney sees as blood flow and how much it can filter per minute. The urine albumin creatinine ratio, it just tells you how much protein you have in your urine. So the kidney filter all the blood, it gets all the dirty stuff and the water out. If the kidney is damaged, if the kidney is in good function, it should retain all the protein, and albumin is the most frequent protein that you have in your blood. If your kidney is a bit damaged, you leak some protein in your urine, and so that's a marker of how your kidney is intact or damaged. And in cardiovascular disease, it has been shown to be a predictor of bad outcome if your kidneys are damaged. So we looked at all the people with a Fontan circulation from Australia and New Zealand who were more than 8 years of age, and we had 151 patients enrolled in the study, which makes it one of the largest, if not the largest, cross-sectional study and the most extensive one for sure in its kind. These are numbers that were coming from a previous analysis, but grossly speaking, they remain the same. The median age, so the average age at Fontan was around 5 years of age. At the time of the study, we had around 20s. You see the age distribution, and about 13 years after Fontan. So what we see with the FibroScan is that if you look at the quoted normal values, and you have different cutoff, as you said, yes, the FibroScan values are abnormal and elevated. If you look at the Fibro test, that's the amalgamated score that you get from different blood results. And so we send all the results to some research lab in Paris, and they make the analysis and they come back with the scoring, which tells you a little bit the health of your liver. And if you compare to that, if you look at that, well, 30% have really abnormal results. 50% are on the edge of abnormality. If you look at the glomerular filtration rate, it seems like I haven't shown that, but it seems that if you look at the Fibro test and the Fibro score, the more time goes by, the more buildup of fibrosis you have, the more impairment of the liver you can have. So it seems like related to time. And the same is true with the glomerular filtration. The more time goes by, the more glomerular filtration decrease. But the impairment is actually mild in the majority of the cases. There's no severe dysfunction, no moderate dysfunction. If you look at the patients with microalbuminuria, which means the people who are excreting a bit of protein in the urine, the decrease in the renal function, the decrease in the glomerular filtration rate seems to be quicker, but it's very, very preliminary data, okay? Peripheral venous pressure, when we looked at it, it seems to be remained constant, and in my next talk, I'll talk a little bit about that, and there seems to be no relationship with the pressure in the veins, and the time since Fontan, the renal function, or the kidney function. So what we have seen is that the Fibro test score seems to correlate with the FibroScan. So we were not sure whether the FibroScan is interesting or not, but it may be interesting. It's still early days, but there still seem to be correlation between this amalgamated score from the blood results and the FibroScan. There's no correlation between the glomerular filtration rate and the FibroScan and a fibro test. The predictors of a worse fibro test score is male gender, and we've discussed that. It's better to be a female for once. When you have a Fontan circulation, you seem to be doing better. And when you look at all outcomes, females, for a very unclear reason, seem to be doing better. The time since Fontan, so the more time goes by, the more impact you have, and you see that on the glomerular filtration rate, FibroScan, fibro test values, as explained. And you may be a bit agitated by these results, but it depends what you look at. So I try to look at on a clinician perspective. If you look at what the GP, myself, what will take as face value, the things we've been taught in medical school, which are this AST, ALT, these are the things that we look for normally for the liver function test. Well, the average is within normal, and the proportion of people who have the abnormality is quite small. So some numbers are a bit more elevated. I don't know exactly why. The bilirubin, which is the thing that is excreted by the liver that goes into the gut and gives the color to your stools, is a bit elevated. But the majority of most of the numbers are not very elevated. The very important thing is that we could not find nodules or frank cirrhosis in these 150 patients, and there was absolutely no signs that any patient had any early signs of cancer. So yes, fibrosis is there, you can detect fibrosis, but not to the stage that it would lead to cancer in what is one of the largest studies of its kind. Then it opens some possibilities. Liver fibrosis, there's not much that can be done, but some world experts on the topic have now expressed that they've started in a few patients to use spironolactone, a very common drug that is used, but has specific anti-fibrotic properties. It decreases the development of scar tissue. Completely new, completely experimental, but maybe an interesting avenue. For the kidney, the real question is that, will everybody be affected? Will it impact everybody or not? How fast will that evolve? And can we do something about it? Well, then that gets interesting, because if you have kidney dysfunction, whatever cause it is, if it's caused by hypertension, high blood pressure, if it's caused by diabetes, whatever cause of renal failure you have, there's one medication that works, is AC inhibitor, angiotensin convertase inhibitor, so enalapril, captopril, and a lot of you kids have been on this type of drug, so we can use it in a Fontan circulation. And we have zero idea whether this can be efficient or not, but that's something that can be tried. And so we're intending in the near future to test this, and we don't know in how many patients we're going to test it, because we have no idea of the impact. But as a first shot, we would like to randomize, so try 40 and 40 who have some degree of renal dysfunction, and we've identified them already. We'd like to offer those who have already participated and who have a hint of something on the kidneys already, to try it with or without drugs for a year and see the glomerular filtration rate. And the criticisms to that study has been that, why do you want to do that? Because, well, there's no impact on the kidneys. I mean, we don't see the people with a Fontan circulation having kidney problem at this stage. Well, do we need to wait that they have problems to try to do something about it? I mean, all we understand now is that with the Fontan circulations, you have complex interactions with the kidneys, with the liver. The whole body is functioning differently, and the gist we have from experts is that It's all these imbalance in the different organs that will determine how well you're going to live and how long you're going to live. So every bit is interesting. I don't think we have to wait to have an impairment and to notice that we have a real problem to try to prevent it. We know that there's something's happening. What about checking before we get any problem? So I got you very excited, I would think. And you know, you may have skipped a few heartbeats while I listened to my talk. So maybe I'll do a bit of Tai Chi or something, because so I'd like you to breathe in, relax a little bit, because I'd like you to remember only one thing. Okay, the only conclusion of what I'm going to tell you is that yes, the Fontan circulation puts strain on the liver and the kidneys. I think there's no doubt about that. The things to remember is how much strain and how much impact it will have on those with the Fontan circulations remain to be determined. It's early days and we don't know much yet. So don't get excited yet. We're going to find solutions, and I want to find solutions for Victoria, who's a student, and I love to show this picture. I think she's beautiful, she's bright, she's brilliant, and she's going to work as a doctor in the Children's Hospital next year, and I want to find it for all of you. Thank you very much.